today. This is actually a wonderful seminar. I love all of our seminars, but I'm particularly excited about this one because it's part of our CHEPS collaboration. And so we have two speakers today, as well as some of the other members of the team. So Michelle and Jordan, where'd Jordan go? Oh, there you are, Jordan. Michelle and Jordan have also been contributing to this work that we're going to hear about today, and it's a great pleasure to introduce Dr. April Ma. She's an associate professor at Emory University in Georgia at the School of Medicine in the Department of Ophthalmology. She joined Emory and the Atlanta VA, the Veterans Association, in 2008, where she's remained as an active practicing clinician as well as a clinical researcher. She currently is the clinical director of TECS, which is Technology-Based Eye Care Services, a tele-ophthalmology program for the Veterans Integrated Service Network based in Atlanta. And she began her career in telemedicine around the year 2012. When she first began doing research at the VA on veterans' eye disease prevalence and piloting studies to use telemedicine to improve eye care delivery. In 2015, she was awarded a pilot grant from the VA Office of Rural Health, and she's going to be talking in particular about reaching our veterans in the rural community. TECS, the program, has grown to also include Missouri, Nebraska, Montana, and Illinois, and currently serves as the National VA RH National Program Office with approximately $2 million a year to continue spreading tele-ophthalmology across the country. And she's going to be joined by our very own VanDeusen, a PhD student. Yes, go ahead and clap, John, that's fine. Hasn't done anything yet, but Adam's one of our PhD, actually my PhD student, if I can say that, in the IE department, working with Dr. Amy Cohn, with research looking at OR methods of public health policy and primarily access to care. He previously worked as a health systems engineer at Mayo Clinic, you can clap again, John, as well as senior director of clinical programs at the Health Management Academy, and he earned his bachelor's degree in industrial and operations engineering here at the University of Michigan, as well as a master of public health and chronic disease epidemiology at Yale School of Public Health. So he slummed it for a little while, but now he's back. And as always, please do ask questions as they come up, as well as at the end of the talk, and have good questions. The card's not for asking questions at the end. The card's for writing down a question in the middle. So Andrea and I are going to grab your cards, whether there are questions on them or not, for those of you registered. And with that, there's nothing left except turning it over to Dr. Ma. So thank you very much for being here.
Well, thanks for having me. I'm really excited, and just so you guys know, I like to encourage audience participation because I know it's the end of the day, we're all a little tired, so I don't want anybody to fall asleep. So we're going to ask for participation, and if not, then I will, I guess, pick on people, but don't make me do that, okay? So just participate. So I don't know, every time we do a slide, we have to say no financial disclosures. And so we have three major goals for the seminar today. And we're first going to talk a little bit about eye disease, give you a little bit of background for those of you who are not familiar with telemedicine and eye telemedicine, and then talk a little bit about the program that we run in Atlanta and why we have this wonderful collaboration with Michigan. So I want to start by telling you all a story. So about 3 or 4 years ago, I had a veteran who was 72 years old. He lives in Blairsville, Georgia, which is nestled in the mountains and about a 2-hour drive from the main Atlanta VA. And he comes in one day and he says, "Doc, can you please give me some glasses because my eyes are weak?" And so I said, okay. So I sit down and I start taking care of him. And then I discovered that he has a problem that I can't fix with glasses. In fact, I discovered that he has advanced open-angle glaucoma and that he's actually now legally blind from his glaucoma, and I have to tell him that he's actually not legal to drive home because his vision isn't good enough for that. So I want you all to play along with me, and I want you all to just take a moment and close your eyes. And let us assume for a moment that you have to live the rest of your life this way. Just think about how you would do your studies, take care of yourself, take care of your family members. How do you enjoy your life? Okay, so now we're having everybody open their eyes because I wouldn't want you all to invite you to take a nap. But, I mean, let's face it, like if you had to go through life visually impaired or completely blind, that's a horrible way to live, right? And it causes all kinds of problems. There's a lot of research out there that shows that if you're visually impaired, you're gonna end up in a nursing home sooner, you're gonna fall down and break your leg, you're gonna be very depressed, you're gonna be more withdrawn. And so vision is critically important for our veterans. And it's a high priority for patients, and people need to get their eye exams on a regular basis because that's some of the ways you're going to catch some of these diseases that might be silent for a really long time. So, okay. So now I want to ask for some audience participation. Can you all think of reasons why Mr. C, my patient, didn't get his eyes checked on time? What possible barriers could he possibly have faced? Go ahead, just shout it out.
Like being 2 hours away.
Yes, exactly. So he's really, really far away from where the eye clinic is. Any other, that's great. Anything else?
And it's not just the distance, but like in his own life. So taking your 2-hour drive, take a full day.
Exactly.
So
it's not very,
exactly.
it's not very convenient. He probably thought everything was okay. That's perfect. More.
His insurance might not cover it.
His insurance might not cover it.
Like education, I see that he was just going blind. Like not being able to see, he didn't know that it's not supposed to go black.
Exactly. Anybody else? Anybody else have any other questions? Or
Like hospitals.
Yep, absolutely. We see that a lot. Yeah, great. So you guys are thinking of all the sorts of reasons why patients don't necessarily get care as often as they should. And so these are some facts that I wanted to point out. Eye disease is more common as people get older, okay? And that they really, because it's more common as they get older, we say that once you're over 65, you should get an eye exam every 1 to 2 years. But you don't for all of the reasons that you all mentioned. And so, and especially if we're talking about an older population, they're more likely to retire and live in a rural area, and then they have access issues because they live really, really far away from the specialist. Or they may be kind of sick with other eye diseases, and they get really tired of going to the clinic, they're just tired of going to doctors. We call that doctor fatigue. Or they have limited income, they have insurance issues, they may be dependent on someone else to travel. So all these, they don't want to be a burden, all these reasons, they don't end up getting the eye care as frequently as they want. All right, so now that we kind of understand what some of the barriers our patients might face, let's talk a little bit about, does anybody know what the leading cause of curable blindness in the entire world is? And does anybody know what #1 cause of incurable blindness or leading cause of blindness in working age adults? Working age adults meaning like, 20 to 55, something like that. Go ahead, just shout out any, sorry, I know you're eating.
Cataracts, right?
What, say that again?
Cataracts.
Cataracts, perfect. What else? What are common eye diseases that you all have heard of maybe? Glaucoma, you should know that, right? Because Trevor's doing that glaucoma project. Any other diseases that we've heard of?
Macular degeneration.
Perfect, and then one more.
Diabetic retinopathy.
Diabetic retinopathy. That's perfect. So the top 4, the big 4, you guys know it all. The top 4, cataract, glaucoma, macular degeneration, diabetic retinopathy. So cataract is the leading cause of curable blindness in the world, and luckily in the US, it's actually not really a problem because most people can at some point get to see an eye doctor and have cataract surgery. So like in third world countries, cataract is a much bigger burden. But glaucoma is the leading cause of irreversible blindness in the world, and macular degeneration is in the Caucasian population also a high cause of vision loss. And the diabetic retinopathy if you're diabetic, and we all probably have heard about the public health crisis for diabetes, so all of those patients that are diabetic require routine eye exams, and if you kind of look at the system perspective, there's so many diabetics in the world that all the eye doctors in the entire US would have to see one diabetic patient every 10 seconds to actually give them those exams on a regular basis that they need. Okay, so just to give you guys, so eye disease in the VA is very, very similar to this, but our veteran population is generally older than the US population. So the average US population I think is about 30, 35, but our average veteran population that we're treating is about 55. So their risk for eye disease is therefore higher because they're older. And then we also have a higher rate of minorities. And that matters because glaucoma is much more likely to affect the minority population. And then we also have a higher rate of diabetes in our veteran population than in the general population. I think some of that is due to exposure. So a lot of our veterans, especially in Vietnam, were exposed to a chemical called Agent Orange, and that's been known to cause diabetes. And so we have a lot of diabetics in the veteran scenario, that in the veteran system that need to be screened. Okay, So let's shift gears a little bit. We talked a little bit about eye disease and like why patients don't get the care that they need on a regular basis. And so now we want to talk about the eye delivery system, because you guys are industrial engineers, you're talking about systems, right? So if you just do you just go and get an eye exam, you have what I call the clinic visit model. And what you do is you have a group of patients, right, the veterans, and the veterans need eye care. So they're gonna go to a clinic. And there's nothing wrong with this method, okay? So they're gonna go either to VA optometry, or they're gonna go to VA ophthalmology, whoever has an opening to see them. And now we have another option called community care. So the VA has a lot of trouble keeping up with our growth and getting all our patients the care they need. So in community care, the VA kind of acts a little bit like an insurance company. So the VA says, all right, Mr. Smith, you live really far away, you can go to the local optometrist or ophthalmologist and we'll pay for that. So we kind of act like an insurance company in that perspective. So this doesn't look too bad, except now you start adding layers of complexity to that. So we already know that there are some barriers to going to the clinic, right? You guys named them, right? Time, travel, distance, and if you're rural, you might not have that specialist really anywhere close to you. And even if you're in the community, you might be waiting 6 months to get in because there's not that many community providers. And then, we have patients going back and forth between VA optometry and VA ophthalmology. You might have VA ophthalmologists sending patients to community care. You might have VA optometry sending patients to community care. Frankly, we don't know what happens to them after they go to community care. We're not really sure. Do they get back to us or what happens to them out there? And so this is kind of messy. It's really, really confusing for patients. And I think that many, many points along this way, patients get lost in the system and they drop out of that safety net and that they don't get the care that they need. And so what we decided to do in Atlanta in 2015 was we said, we need a better tool. We need a better method, something that can help us address the growth that we have, but also something that allows us to take care of our patients closer to home, try to mitigate some of the barriers that they face. So we settled on a telemedicine model. So just briefly, telemedicine is defined as when you give care to a patient and you're not in the same place as the patient. And I kind of think of that care being divided into two major groups. One is synchronous. I just think of it like Skyping with your patient. You're looking at that patient right then and there, doing the exam through a video screen, and that's kind of synchronous. And then the other side is asynchronous, so store and forward, meaning we take some images or we get some information, we put it in a server for a period of time, and then that information is looked at afterwards, and then you give the patient a result later. Ophthalmology has typically used store and forward, and that's kind of the method that we're using right now. And just so you all know, the University of Michigan is really invested in telemedicine in general. So not just for eyes, but for all sorts of different things. So these are just some examples of different ways that you can do telemedicine. So you can see that it's pretty robust in terms of across medical specialties. A lot of places end up using the synchronous version or the video. So like telepsychiatry, teleprimary care, tele-rehab, a lot of that is done via direct video connection. And like specialties like dermatology, eye clinic, we are image-based and pattern recognition-based, so we use the images for, we use more store and forward. Okay, so I know you guys are all burning and wondering to know what exactly is TECS. So what we do is, this is what we end up doing. So we put a dedicated ophthalmology technician at the primary care clinics. And that job of that technician is to collect info for the doctor. The same kind of information you would get if you went in for an eye exam. So we would do history, we do history, vision, we measure for eyeglasses, we check other important ocular things like pressure, and we put that together with a bunch of photographs, and we send that to a doctor who then puts in a note. We have some protocols that kind of help us guide the kind of care we give, and everything is done in a really small space. And that's important to us because in the VA space is at a premium. It's very difficult to get space. So the more you can do in a small space, the more value it shows to the system. And so that's kind of how TECS looks. So if you're an eye doctor like me, and you're looking at this schematic, you're thinking, I'm getting all the information I would normally get on a patient The only difference is that I'm looking at the front of their eye and the back of their eye through pictures instead of looking at them in person. But otherwise, I'm getting a lot of information, same kind of information I would normally get if I was in the clinic. And so because I think pictures are worth 1,000 words, I'm going to show you a picture of an actual TECS site. So this is one of the actual TECS sites that we have. You'll see we only have 2 pieces of equipment, and then the eyeglasses are like on the other side of the room. And so with just a little bit of equipment, you can basically take care of a lot of patients and do a lot of things for them. So what we wanted to do in Atlanta was we wanted to work smarter. We wanted to use the telemedicine tool that we had to change the way patients are actually seen. So instead of going in that initial clinic visit model I was telling you guys about, what I wanted to do was divide what patients needed into 3 levels, and this is the schematic we're using, the basic, the intermediate, and the advanced level. So the idea is that we only have so much money in the VA system. I wish we had unlimited dollars, but we don't. And so we have to spend that wisely. The most expensive is actually the providers. So we wanted all the patients who really need to see a provider to go to the provider, and those that maybe are lower risk and don't need to see the provider to deliver their medicine closer to home in a telemedicine method. So the idea is that we would use TECS as a telemedicine model to take care of basic eye needs. Like, I just need a screening exam, I just need some glasses, that kind of thing. And then use that to triage patients into the intermediate and advanced level. So that instead of like this right here, we end up doing very little basic care in the hospital clinics. And then we do more intermediate and advanced care. So that and then that way also, this helps the patient. So that when they show up, we're gonna say, hey, Mr. Smith, you need to see the retina doctors. You need to come on this day. And so they drive 2 hours to come and see us. It's not to see someone and then be like, well, I'm so sorry, Mr. Smith, now you gotta come back tomorrow because the retina doctor's not here today. So we're hoping to increase our in-clinic efficiency this way as well. So this is kind of my model of what I would like to see our eye care system move to. And so I know you're all wondering now, what does this have to do with systems engineering? It's all great and fine and dandy to learn about eyes and why it's important and all those sorts of things. Well, the reason why we started a collaboration with systems engineering is because now I feel like we have lots of tools in the toolbox to take care of patients. And we have providers at all sorts of different levels and all sorts of different skill sets to help take care of patients. But we still have questions, like, should we, if we have a certain catchment of patients, should we open a TECS site, or should we just spend the money and hire a provider? Or, what is the impact does starting 5 TECS sites in Atlanta have downstream? What kind of things do we need to plan for in the future to take care of the patients that are gonna need care? So these are the questions that we wanted to answer, that I'm gonna hand over to Adam because he's helping me answer these questions.
Thanks, Dr. Ma. Any questions for Dr. Ma on the,
Oh, yeah.
on the more clinical side before I start taking over?
Go ahead.
So, how do you I know veterans are a special population. How did the older veterans feel about not seeing a doctor? Is there any sort of drawbacks to that where they see something else and they don't feel taken care of?
So that's a really, really good question. So what we do is we educate the patient, first of all, that this is a tele-exam, and they always have the choice to not do a tele-exam. So if they just want, if they just want to see a doctor, then we just send them to see a doctor. So we let them do that. What we do is we educate the patient about the process and what it means for them. And I find, interestingly enough, that a lot of patients, if they're not really having any problems and they just want a screening, that they're very accepting of telemedicine. So the VA's been a leader using telehealth for a very long time, partly because of our structure. We don't, some of the things that are barriers to implementing telemedicine outside the VA, we don't have that problem because we're a single large healthcare system. So they're very accepting of it, actually. They love it.
Since you guys are using mostly that forwarding care, and just on the other one, is that harder with the rural patients than this guy with internet access and maybe an older population?
So that's a really good question as well. A lot of times what we do is we're going to do some sort of Skype. It happens at their primary care clinic, so that the internet connections and everything are correct. Yes, we are trying to reach out using apps and things like that, but that is a barrier. Like, a lot of our patients are a lot older, and like some of my patients, I'm like, hey, you can secure message me. They're like, I don't own a computer, and I'm like, well then, never mind. Here's my telephone number. So we just, we have a whole range of different veterans, but we have a lot more Operation Enduring Freedom, Operation Iraqi Freedom veterans that are a lot younger that are wanting to use technology. So we're trying to cater to the whole group. But those are all really good questions. Anybody else have any questions before we let Adam start? Not yet? Okay.
Great, so as Dr. Ma alluded to, this is a really great problem to think about from a systems engineering perspective, and kind of thinking more about what this actually looks like, what kind of tools we're using, what kind of viewpoints we're bringing to the table here. The reason that this problem kind of works for this, for systems engineering is, first, that it's a combinatorial matching problem. So we're thinking about, we have all these potential clinic locations, all these patients who live in specific zip codes, and different ways that we can staff those clinic locations. So we have to really figure out kind of what is the best way to match patients to clinics and figure out which providers should be at each clinic and which of those clinics should open. Also, there's constrained resources in this problem, and we talk a little bit as we go through the results about what actually those constraints look like and how shifting different constraints can have an overall impact on the long-term outcomes. Also, there's a lot of different criteria within our decision, and we'll go through a few different iterations of our models to say, if we want to have different priorities, how does that impact what our results look like? So if we're going to consider our cost as our most important variable, or the distance that our patients are traveling, or the number of patients that we actually get to see, those are all going to lead to different types of outcomes. So when we think about this kind of from an engineering perspective, we're really trying to say, which locations which locations in the VA in Georgia do we want to provide eye care, and what kind of providers are we going to staff at each of those locations? And also within that, how many of each of those provider types? So we do make a few assumptions here. One is that patients, right now for the time being, we're considering that if we assign patients to a clinic, that they will go there. This is a broad assumption, and part of our future work is going to be about relaxing this assumption a little bit. Right now we're just looking at kind of a 1-year time frame, and also that our patients have a homogeneous screening need, that overall there is a certain chance that a patient's going to have glaucoma versus diabetic retinopathy, but all patients sort of look the same. Kind of some limitations with how we're looking at this too, is that right now, for the time being, we're only looking at the eye screening component, so we aren't starting to bring in that follow-up care, the long-term care of, I got screened positive for glaucoma, now I need to go see an ophthalmologist to get long-term care. And we also don't have any consideration right now for patients' provider preferences. So like John mentioned, there might be some patients who don't really want to participate in TECS as much. They want to see an ophthalmologist. So we don't have any of that consideration in yet. So one of the ways that we're looking at this is through kind of facility location model. So quick overview of facility location for those of us who haven't looked at it in a little while. So facility location uses mixed integer programming to optimize where facilities are placed to meet different demands. Usually with facility location models, the objective is to either minimize the cost or to minimize the distance that's traveled. And we'll go through kind of some versions of this as well as we apply it to our model. There are often constraints on where you can assign different locations to meet the needs of your customer base, as well as constraints on the customer demand. And this is usually used in PDL, production, distribution, logistics problems. So a lot of manufacturing, a lot of warehouse placement. You can imagine places like Amazon, UPS, they're going to be using a lot of facility location models. So as kind of how we approach this is to start first at where our possible locations to provide eye care are. So when we think about that facility location model, each of those are potential locations. For us, we have 25 potential VA locations in Georgia. Some of these are sites that already have eye care at them, and some of these do not have eye care currently. They provide primary care and maybe some other resources, but at least primary care. And then we decide at which locations are we going to try to offer eye care, and what kind of providers, or what we could have multiple provider types, do we staff at each location. We then assign patients based on how we've made those decisions, so that patients from all of our different zip codes across Georgia are assigned to a different clinic. And then we also consider two scenarios. The first is kind of starting at our current state where we have some clinics that have eye care, some that don't. Where would we add eye care to that current state to try to be able to meet our objectives? And then we also look at starting from scratch. If we didn't have any eye care currently, and we were just going to add where it was best to meet all of our objectives, what would that look like? How is it different from what our current state is?
From like a cost perspective, on like what it is currently is with
Sorry?
from like a cost perspective of like what the current state is, we should get on this cost and stuff.
Yeah. So with when we look at the current state, for right now, we're kind of considering current state. We're considering kind of what costs it took to get there. So those are in the model, but we can also look at if we wanted to just look at what are these additional costs going to be if by adding more care locations.
So how did you decide on like 25 locations? Is that like, I guess, how did you like sort of decide on that number?
Yep, so that's an input from the potential possible locations of VA eye care.
Did you consider like having that as a decision variable, like how many locations?
So we do, and not in the kind of version that we're presenting right now, but in past versions of the work, we looked at if we were going to add care at kind of like our current state and we only wanted to open one more clinic, where would we place it? Or if we only wanted to open 3 more clinics, where would we place them? For this version, we're just going to look at starting from scratch, what would we add? So as we're modeling this, we're going to be doing again some mixed integer programming. So first we're just going to go through the feasibility constraints and then go through our different objective functions, and with each of those objective functions we'll have a few additional constraints as well. But all of the problems that we're going to solve need to meet these constraints. So first we want to make sure that when we are assigning patients that they're not going to exceed clinic capacity. So that is going to be subject to the type and number of providers we have at each site. So when we're thinking about the different providers, there's the ophthalmologists, the optometrists, and then TECS. So those are kind of the 3 options we can have to provide care. Each of them is associated with different costs, with the ophthalmologist and optometrist being a little more expensive than TECS. And then each of them can also see a given number of patients each day. There's also the demand, so we want to make sure that we're meeting some demand from the patient perspective. And one of the big things we really wanted to focus on is making sure that we're not just meeting some global demand. We're not saying we just want to see 5,000 patients. We're saying we want to see at least 5% or 10% of the patients from each zip code, so that there is some equity in the care that we're providing, so that someone who's living 200 miles away from Atlanta isn't getting less of the effects of this additional care that we're offering.
What's the demand, the overall demand?
Yep, so there
25 locations, but you have enough demand to staff? Meaning, you have all the staff, do you have enough patients?
it's pretty tight, I'd say. You can speak more to that.
I guess I would say that the Atlanta VA, so eye care nationally in the VA is growing about 9%, about 3 to 4% per year. In Atlanta, our growth in new patient eye demand is like 9 to 15%. It's been sustained. So there, at least for the Atlanta catchment, there is definitely more patients than we have current capacity for.
And how long does it take to do one of these tests? I mean, it sounds like to me you can write an AI program to take care of the ophthalmologist. They do the same thing over and over and over. I mean, I have good friends who are physicians who say they go crazy doing the same damn thing over and over. If they tell me what they're doing, I could write an AI program to do it too.
We're actually working on that too. FDA approval is necessary for something like that. But yeah, so automated image detection is a big part of telemedicine.
And that'd be more reliable than the ophthalmologist.
Probably so, in terms of, probably so.
At least you admit it.
But Walt, you still have to take a picture.
Yeah, you take a picture.
But that's most of what you're talking about.
But I know how to scan pictures real quick.
Yep, and so that's when folks like the TECS can come in to help with that picture taking. So then the last feasibility constraint here is just that each clinic can only take on so many providers. We don't want to say, hey, Atlanta's a big city, we can just throw 20 ophthalmologists there. That's not going to really be effective in distributing our care throughout Georgia. So then we're going to look at 3 different objective functions. The first is to say we want to maximize the total number of patients that we are assigning. So this is really trying to think about access from a pure, how many patients do I get to see? With those, we have additional constraints on the budget to make sure that we're not exceeding a certain budget. And then also we put constraints on the furthest distance that patients are allowed to travel. And we'll vary both the budget and the maximum allowable travel distance as well. With them, our next objective function is looking at minimizing overall costs. With that, we have additional constraints on the minimum total number of people that we're screening, and then again on that furthest distance that we're allowed to travel. And then finally we have an objective function that we have all set up, and we're working on making the code run a little bit quicker. And that is to minimize the furthest distance that patients travel, and with those we're looking at additional constraints to the budget, and again the minimum total number of people screened. So all of the kind of the inputs that go into populating these models comes from a few different, well, mostly VA data, and then some additional information too. So we have we're considering right now as our patient base, patients that sought VA eye care at some point in 2017, which is about 200,000 patients, and we grouped them by zip code. So each zip code has a different patient population within it. Then we have our 25 VA clinics in Georgia. 15 of those currently offer some sort of eye care, whether that be an ophthalmologist, an optometrist, or TECS, or some combination of those 3. Between the clinic locations and the patient zip code locations, we calculate the driving distance from each zip code to each clinic location, and we use a Google API to calculate that. And then we get a lot of values from the VA on budgets, costs, provider capacities, and other clinic information. So when we run these programs, I'm going to go through first kind of what it looks like, our results look like for maximizing the number of patients assigned. Just to orient you a little bit here, we're going to look first at kind of the from scratch, and then if we were going to be starting from our current state. And we're going to look at how this changes when we change the budget. And then also we have our minimum percent seen. That minimum percent seen is kind of per zip code. So if we're saying we want to see 10%, that's saying we want to see at least 10% of the patients from each zip code with this model. So you can see, not too surprisingly, as we increase our budget, we're able to see more patients. And each additional increase of $1 million bumps up the number of patients that we can see by about 15,000. And that's for starting from scratch. If we look at our current state, we can see that kind of at any point, $20 million of budget is going to be infeasible at all costs. As a reminder, that's including kind of all of the costs that are already there. So a lot of that $20 million has already been spent. So these, it's a bit misleading about whether or not it's actually feasible. But you can still see, as again we increase the budget, we're able to see more patients. Then additionally, if we want to look at the results for minimizing cost, we can see that here, instead of having the budget down, the first column, we're going to increase the max distance that patients are allowed to travel. So if we're only allowing patients to travel 100 miles, at most 150 or 200 miles. And if we start from scratch, you can see that the costs overall are a little bit cheaper than if we're starting from our current state. But either way, as we allow patients to travel further, we can see from our scratch model that we have slightly lower costs once they're not traveling quite as far. Yeah.
Are patients willing to travel that far?
So the 200 is definitely an extreme case, just to say, like, if we basically threw out any kind of restrictions on travel, that would be like the most, just to show that extreme. I would say 100's probably about as far.
Yeah, so Blairsville, in the example I used, is about it's about 100, it's probably more than 100 miles if you're counting round trip. But yeah, these are really large numbers in terms of distance traveled. So if they can go to the Blairsville TECS clinic, it's usually much closer than 100, it's much less than that.
So are these round trip then? Just one way, or are these one way?
These are one way, yeah. Any other questions? So just kind of looking at next steps then. The next things we're going to be working on, first two, as I mentioned, we're working on a model to minimize the maximum distance traveled objective. We're also going to work on starting to incorporate stochasticity, so being able for patients to go to not their assigned clinic. So maybe if there's a TECS site that's 20 miles from my house, but I have an ophthalmologist that I really like, that I've been to a few times, that's 60 miles from my house, I may be willing to travel to that ophthalmologist. We also need to consider our implications for follow-up care. So specifically, as we start to increase the number of patients that go to TECS sites, there's going to be an impact on the case mix that optometrists and ophthalmologists have, where they used to be doing many more screenings, now it's going to be a lot more focused on follow-up care. So that both impacts their case mix as far as what they're doing day to day, how many patients they can see and how they're seeing them, and then also just the number of different providers that we need. And then also we want to start working on generalizing this beyond Georgia. As Dr. Ma mentioned, this TECS program has expanded to several other regions across the US. So we want to start saying, okay, once we get this kind of nailed down for Georgia and have a good general understanding of how these different changes to the system work, what does that do when we start to look at another location? So before I kind of do conclusions and discussion, I want to do some brief acknowledgements. First, the VA, specifically VanDeusen 7, which has provided all this data, and Dr. Ma, South Bonder Foundation, CHEPS, specifically thanks to Jordan and Michelle, who worked very hard and are still working hard on this, on our current team, and then past team members Mohammed, Dima, and James, IHPI and Improve, as well as Regional Telehealth Services, Charleston Health Services Research and Development Center of Innovation. Heroic.
Yeah. I don't remember what heroic means. They are the ones who do our quality assurance and quality improvement. So I know that those of you who were assigned the article for part of the seminar, that data came from them. They're the third-party data team that makes sure that what we're doing is high quality for patients. So they also are whizzes at getting information out of our corporate data warehouse for things like this.
Yeah. Great, so that is about it. I don't know if you have any other closing remarks that you'd like to make.
I do not.
Okay.
I might join you at the
Great.
because they might ask questions.
Yep.
So I'll stand up here.
Yes.
How about another model where, and you go in every community, there's usually an optometrist.
Yep.
So let them do the basic work.
So,
And if there's a problem, then kick it up to your folks.
as in going out to the community.
Yeah, I mean,
Yep.
to have the VA just be exclusive to what's in the community, I question it.
So that's a really good thought. In fact, I started TECS in Montana. That is essentially what Montana does. They have 3 ophthalmologists for the entire state. They have 1 VA for the entire state.
Yeah.
And that's what they do. They send all of the routine eye exams out to the community. The issue with that we have is that actually becomes very expensive for the system because we like to keep the patients in-house. Partly because some of the veterans like to get care through the VA, they would rather not go out to the community, but there's an extra cost of actually coordinating that care out to the community. So that actually becomes quite expensive. And recently, we were paying a 30% off the top coordination fee to a company. So we would pay Medicare rate for an eye exam, which is like $160, $120, but we pay 30% on top just to the middleman to organize and stuff. So it does, part of the reason why it's better to keep them in the system is because it saves money down the road.
Except that the people have to travel 100 miles.
Well,
If you
so,
take into account their total cost,
right,
it might be a little different story.
And within our model too, we have those costs associated. So if it's going to be cheaper, especially for the models where our objective is to minimize cost, it's going to be cheaper, then that's what will happen. They'll be sent out into care, community care.
I noticed that when the model where we would kind of maximize the budget, because of 22 million, like the number of patients that were treated was about like 60,000.
Uh-huh.
I remember the demand was about 200,000. Is that correct? Is that like an issue that, I don't know, it seems like there's a lot of people who aren't being treated.
Yeah, so, and Dr. Ma can speak to this more too, but one of the things is this is screening on a yearly basis, and depending on kind of what regulations we're considering, seeing every single patient in 1 year is maybe not going to be something that we want to do.
yeah, so not every patient needs an eye exam every year. So the 200,000, I think, is the number of veterans that live in Georgia that
That are seeking care.
that are seeking care. And some of them actually do have outside insurance that they will use, and they may use the VA as like a backup or a safety net. So even though there's like 200 patients, it doesn't mean that we have to see all 200 patients. So that builds in a little bit. And so if you see them, if they're for screening, you see them every other year. And there are some patients that have very sick eyes and are not appropriate candidates for a telemedicine type program anyway, so that changes the numbers then from the 200,000. But no, I mean, what you bring up is one of our biggest problems is that we're growing like this and we can't build our clinics fast enough to meet that demand. And so a lot of different people have come up to me and said, well, we like this program, like, you know, should we put it on a van and start driving it around? And I think that, you know, that certainly is something that we can do. It's more costly to run a van than it is to have, you know, to take a little room that's already in an established primary care clinic. But it's certainly something we can do. I love this. I love the fact that everybody has questions and stuff.
So I was wondering if you have any like integration problems in terms of working with CPRS, and if you expect or anticipate any increased capabilities with Cerner.
So we built TECS off of the VA's already pre-existing diabetic teleretina program, which uses CPRS.
Can you tell the rest of us what CPRS is?
I'm so sorry. CPRS stands for Computerized Patient Record System, and for those of you who have not been to the VA, it is the electronic medical record that the VA has used for years. And so the good thing about the way the VA works is that our IT structure in terms of EMR is uniform across the country. In terms of CPRS in Atlanta looks the same as CPRS in Ann Arbor. So what I did was there were many things I tried to change about the VA system. IT is not one of them, because I probably would never see any patients if I spent all my time trying to change the VA IT system. So I just used what already exists. So that pathway in terms of transferring data, being privacy compliant and all those sorts of things is already established. So we don't have any integration issues with CPRS. And you asked me about Cerner. Cerner is kind of a new thing. I'll believe it when I see it, when it shows up on my desktop and I'm being forced to use Cerner, then I'm going to, you know, deal with Cerner. Somebody had a question over here.
I was wondering if you could talk a little bit about like factors behind eye disease, because you mentioned that Atlanta has like 3 times the national average of, you know, people who are seeking like care for eye disease. Like I was wondering if you could talk about what some of those factors were that was causing that trend.
So it's primarily based on growth. So the southeast United States is growing at a pretty rapid rate. And Atlanta as a hospital within the entire VA system so the VA takes all their hospitals and divides it into levels of complexity, and 1A is the most complex, and we're associated with a university. So I don't know for a fact, but I would assume that your Ann Arbor VA here, because it's associated with the University of Michigan, is probably a level 1A. So very complex, offering all sorts of different subspecialties and things like that. So there are smaller hospitals in the more rural areas, for example, that, you know, basically don't have emergency room services, and if you get really, really sick, you gotta be transferred because they don't have the inpatient capacity. So I think the reason why we have so much growth is just because there's growth to Atlanta. Just veterans are moving south. a lot of people want to retire, and the South is a little bit warmer and things like that. Like, your high is my low, right? So, so I was like, oh, I got to wear more clothes. I got to bring more warm clothes. So, I think a lot of this is demographics, just the aging population moving south, and we're seeing that growth trend. The one thing that I will say, which at some point we may be able to incorporate into the model, is that part of the reason why I think eye care in the veteran system is so highly in demand is because the VA provides glasses for free for veterans. So if any of you ever wear glasses, glasses are pretty expensive. Like, you can easily pay $200, $300, $400 for glasses. And so a lot of our veterans, live on a limited income, and they don't, they want to get their free glasses. So that's the big carrot that gets them to come. But I want to use that carrot because I know they'll come back if I give them glasses. But then I take the opportunity to screen them at the same time, so we did some numbers a while back with our quality data, and if you take everybody we screened, about 8% end up with something serious that maybe they didn't know they had. So it's not a small percentage. So our return rate in terms of referral is about 30%. And that seems really high. Like, a lot of people are like, well, you're just over-referring people. I'm like, not really, because if you look at, no matter how you slice and dice our data, the referral rate in from a screening program is anywhere from 20 to 30%. It's just that's our population.
Yeah, well, first of all, great report. I'm not an engineer, but it's a type of analysis that makes me want to be one.
Awesome.
Well, I had a question for Dr.
You could become an ophthalmologist.
I could. Maybe this will reflect my training, but could you give us a sense of the policy environment at the VA right now? Is there appetite for this expansion?
So that's a very good question. So the VA recently passed several laws, and one of them, which is this is the way the VA does it, they come down from on high and say, you're going to do this, and we're like, we can't do that. But so it is, the environment has never been better for telehealth. I think the environment in general in healthcare has never been better for telehealth, but especially in the VA. So they came down with a mandate that said that all hospitals need to provide 20% of the care they deliver veterans, any kind of care, by tele. So this is huge because we're nationally across the country, we saw more than 5,000 veterans this past year through TECS, and just pockets of it all over the country. So that's a huge amount of telehealth that we're delivering. And then recently the VA policy-wise from Congress and from our VA secretary passed a law that called the Anywhere to Anywhere care, which basically means that if I'm a provider in Georgia, I can read for Montana, and as long as it's within the VA system, I'm good from the credential. I get credentialed, but I'm good from that perspective. I don't need to go get myself a Montana state license in order to practice. That is a problem outside of the VA. That's one of the biggest barriers for telehealth adoption. And the other thing that makes it very appealing to the VA system to do telehealth is that we're a closed system, right? So one of the big things is if you're in private practice and it costs money to buy this equipment, to send people there, you need to be able to get reimbursed for it, right? And insurance right now doesn't really pay for store and forward. I think that's changing, but in the VA, that's not our concern. We don't care about billing somebody for that.
Sorry, with these policy changes, was there did it come with budget? Did it come with money? Could they afford this $20 million?
I wish that was true. That's a little bit harder. That's a little bit harder to get through. There are pockets of funds, and so that's why it's kind of for TECS purposes. So now what we're doing is we're using the seed money that we're getting from Office of Rural Health to kind of help cover some of the cost, and then asking the medical centers to cover some of the costs and to basically mix cost. And truthfully, the medical centers have budgets, and so they have business models and things like that. So what's happened is if right now you don't have access, which means you cannot get a new patient in within 30 days, you have to send them out to community. That's kind of the new rule. Community is going to cost you $160 plus per patient. So if you can save that money and bring it back into the system, you can use that money to start the program. And so that's where the balances come in. But that's always a challenge. Resources is always a challenge. Space and money.
There seems to be a push for telemedicine across the industry, but what is the tipping point where the risks, what are the risks, and to what extent is it going to be detrimental to have so much of our visits through telemedicine?
That's a really good question. I think when you start a new telemedicine program, one, you have to prove that before you do it, that it's actually safe what you're doing. So what we're doing is very safe, and there's a lot of literature that shows that just doing pictures, like not even getting anything else, like no vision, no eye pressure, nothing, just getting photographs, that you've been able to diagnose a lot of different diseases. So there's already that background literature that works. And I think you just have to know, you really just have to be safe, you really just have to target your population appropriately. And so, and that's just a clinical decision, and then ongoing QA/QI, which I think is really important. So, it's kind of a funny thing, but how many of you have heard that if you go to one VA, you've only seen one VA? Have you guys heard that? Like, that drives me crazy. Because I'm like, we're a system. Like, it shouldn't be that if you go to Montana that you're gonna get different eye care in TECS than if you come to Atlanta. I mean, that's not fair. And so, you know, I think if you have a very robust QA/QI that can capture problems or indications of problems before you start, then you can keep it within the safe realm. And we literally have it built in. Like, patients will show up anywhere and they'll be like, I have advanced glaucoma and I want you to take care of me like in Blairsville. And we just have to explain to them, you're not safe for this program. We just tell them, you know, and usually they're okay with it.
So at the end, you sort of talked about the possibility of expanding this methodology to other, I guess, clinics. Can you talk about like other clinics that you think this would work? And also like, is it other than eye clinics or other than telemedicine? Like, can you talk about like stuff that you thought about?
Yeah, so I was referencing specifically some of the other TECS sites that are starting to open in the other states that Dr. Ma mentioned at the beginning. But certainly, you know, this kind of approach is a kind of a way to be thinking about any sort of system where you have sort of the similar combinatorial matching problem of I have constrained resources, I have different provider types, and I have patients who need to get places that may be far away. How can I start to think about them? So off the top of my head, I'm guessing like dermatology is probably something that could have a similar system applied to it, finding the right clinical collaborator to do that.
I belong to the regional telehealth services, and all we do in my service line is telehealth. So we actually have teledermatology, teleprimary care. We're trying to onboard like telerobotic stroke rehabilitation, and then eye is a big component of that. So yes, I think whenever I think about store and forward telehealth and what I'm trying to do, like the first thing I think about is Dr. Chen, who is like my counterpart. She's a dermatologist, and that model has different things, and a lot of that can actually be taken care of by the primary care doctors, and so they're, you know, but that is definitely true because, I mean, there's not that many dermatologists, and if you live in like Dublin, Georgia, like you're out of luck. Like you're not going to be able to find yourself a dermatologist if you need one. So, yeah.
Okay, I know that you want to get together with your groups and get work going, and I think Dr. Ma can probably take a few more one-on-one questions, but let's go ahead and thank our speaker and